It's a pleasure to be here. So we still don't know what the ideal aortic valve replacement is. Mechanical prosthesis is still the gold standard, but we're talking about lifetime management of AS, basically due to the rapid expansion of TAVR and patient-related factors that Mauricio alluded to at the beginning. And that's dictated by the patient's preference to avoid anticoagulation, much like that lady that Mauricio talked about, and a lot of the patients we see, and the driver of us implanting approximately 93% of bioprosthesis in the aortic position. And with that, we've seen a decreasing risk in reoperations, so that's good news, at least for surgical AVRs. But the rapid expansion of TAVR into younger patients less than 65 years old, and as a consequence, more patients with bicuspid aortic valves and aortic insufficiency associated with AS complicate the picture. So to try and set the playing field, we have to go back to what we know, and for that, we got to step back to 2013 and look at this study, which is a very good and interesting and extensive study, looking at over 12,000 patients operated on Cleveland Clinic between 1982 and 2011 with a mean age of 71 years. And this tells us a lot of what we know already, and it's that the higher the gradient at the time of the operation, the higher the risk of structural valve deterioration, as a consequence, a need for a reoperation in the future. Nevertheless, since you're looking at patients that are 75 years old as mean age, the number of explants for structural valve deterioration was not very high due to the competing risk of death. Now, what we do know is that out of over 12,000 patients, only 354 explants were performed, and younger age definitely increased the probability of explant, as you can see on the screen on the right. Now, when we move on and look at low-risk patients within that same population, now between 2005 and 2017, you can see that in a center of excellence, such as a clinic, operative mortality can be taken down well below 1%, and that basically negates the advantage of TAVR early on when you look at that particular environment. And there's something that's very important to see and appreciate, and it's the temporal improvement in complications and morbidity associated with the operation, as you can see over the time of the study. And in these patients with a mean age of 65 years and an STS PROM of less than 4%, you can see that the survival was durable and that the explant rate was also very low, with patients having a survival or an expected survival that was very much the same as an age-matched population. So standardization and continuous improvement can lead to outstanding results that are generalizable. TAVR benefits do appear to be durable and support early intervention. And reoperation continues to be uncommon at less than 7% at 70 years, of course, due to the competing risk of death. But this basically sets the playing field for what we need to look at with TAVR and the risk of reoperation. And this study out of the STS database by Badawar's group, who have been very active recently publishing about this topic, shows us that when you look at a low-risk population, and this is over 100,000 patients between 2018 and 2020 at a mean age of 69 years, you can see that when you do a risk adjustment, there is a difference in favor of TAVR already at 3 years, which I thought was very interesting. And when you take the low-risk cohort, that continues to be the case. And when you look at not just survival, but survival free of complications such as death, stroke, or reintervention, the difference is even stronger and continues to be present not only in the overall population, but low-risk cohort. Now, despite that, this is what we're seeing. This, again, is a very recent paper by the a group from California, showing the progression of TAVR implants in patients under 65 years of age. And you see that it went from 7.1% in 2013 to more than or almost 55% in 2021. So that's quite the change. And of course, that's driven in part by patients' preference. And I've been exposed to that here in Florida. It's quite impressive, and Mauricio's case highlights exactly that. But then when you look at the survival within that group of patients, it's even more impactful than what I showed you from the SDS database. You can see that the expected survival, or the survival at 6 years in this group, is significantly better when you look at SAVR versus TAVR. Because SAVR after TAVR is just not pretty. It's not an easy operation. It's very technically challenging, and as a consequence has very high early and 30-day mortality, even in the best hands. And what we're seeing is that SAVR after TAVR is right now the fastest growing operation in the United States, with a 5,914.3% growth rate between 2012 and 2023. I didn't make that number up, it's actually written. Which means the growth of SAVR after TAVR is of 148% per year. And the greatest growth comes on after 2019 with the approval of low-risk TAVR. The current trends of reoperation after SAVR and TAVR, you can see here out of this paper by Hawkins, they already saw that in 2013. You see that for SAVR, it's pretty stable. And of course, increasing for TAVR, right? SAVR after TAVR. And this projection shows exactly what I showed you in the previous slide. And that holds true for us as well. Now, the reality is, it's not that many patients. When you look at the absolute number of patients versus the number of valves implanted, it's not that many. The number of patients, it's not 17%. It's more like 1.7%. But with the number of valves that are being implanted, it accounts for a very large number of patients. And the results, as Dr. Desai had mentioned, are not very good. You can see that whereas the mortality for SAVR after SAVR is 9% in the SDS database, it actually goes up to 17% when you have a previous TAVR. And when you look at the different groups, it can go up to 20%. So the observed to expected mortality is actually 2.4. So what are the key takeaways? I think that early mortality benefit of TAVR may be negated in centers of excellence, and that's important to bear in mind when you're looking at a low-risk population, particularly younger patients. Late event-free survival benefits SAVR, perhaps because of the higher incidence of PVL, especially in bicuspid aortic valves with TAVR, and a higher incidence of need for a permanent pacemaker. The expansion of TAVR indications in low-risk patients leading to its application in younger patients that we should probably reevaluate. TAVR explant then is now the fastest growing cardiac surgery in the United States. And although the absolute numbers are not high, the mortality is, which means we should probably start thinking about a SAVR first approach in this patient population as part of that lifetime management of AS. Thank you very much.